Moving along to the physical exam portion, the portion before we discussed the anatomy, now we are on to the actual physical components. When we talk about the physical exam, of course, I'm going to start out with washing my hands, either with soap and water or with a hand sanitizer, introducing myself to my patient and explaining to them that I'm here to do a chest examination, listening to their lungs. The first step you're going to do, and remember the look, listen, and feel, is that we're going to visualize the patient's posterior chest wall, their posterior thorax, looking for equal bilateral chest rise. Once we have visualized that while they take breaths, there are no freely moving segments or flail segments, and they are having equal bilateral chest movement, we can then place our hands in the situation you want to make sure you have as much skin-to-skin contact as you can. And as they breathe in and out normally, you're again feeling for that symmetrical chest rise and movement. Notice how, with my hands off of the chest wall, the presence of my fingers are spread out so I can feel that movement of the patient's chest wall. Once I have felt that chest wall movement and verbalized that it is equal and bilateral, I can then also, if the patient does have a pneumonia on one side, if I felt any unusual vibrations, because remember, vibrations are turbulence within the bronchioles, you can feel what is called tactile fremitus. Tactile fremitus, like our petroliloquies and egophony, is a sign of consolidation in the area where you feel the vibration. Once you have done the palpation, you're then going to move on to percussion. You're going to start on the right-hand side in the right upper lobe, with my pleximeter finger striking. If you have dullness, it means you have consolidation. When you get down, again, skin-to-skin contact is necessary. Normally, you would go side to side as you're going down and doing your percussion. Once you percuss the chest wall, then you want to go on to your auscultation. Utilizing the diaphragm, initially, you're going to start on either your upper right or upper left. Most of the time you will be presenting to the patient's right-hand side. So start up here, have the patient take a deep breath with the right upper lobe. You then move over to the left-hand side for the left upper. And as I go progressing down, in a stepwise progression, remember that I need to have skin to stethoscope contact. Doing 3 or 4 on each side, alternating back and forth, auscultating for lung sounds. If you have an abnormality or a place where you have an abnormal lung sound, you would then go back and retest that area with either whispered petroliloquy, bronchophony, or egophony. Or also place your hand on the chest wall where you had the abnormal lung sound and check for the tactile fremitus. From this side as well, you can move, have the patient raise their arm to the stethoscope, being into the axilla on the patient's side, catching on the right-hand side, that right upper lobe, catching the right middle lobe, and then catching the right lower lobe. So again, right upper, right middle, right lower. You would then go to the patient's other side, remembering that on the left-hand side you only have 2 segments where you would have the patient raise their arm, listening for the left upper and left lower as they auscultate and take those breaths. Now, when we look at the anterior assessment of the patient's chest wall, you can do this from either a fully seated position, a 30-degree position like we have the patient in, or you can do it supine. For our testing purposes, we would like you to do either a seated position or a reclined position, because our next exam is going to be the abdominal exam. And we want to make sure that we're not making the person lay down, sit up when we're thinking about doing the exam. So we have a little bit more fluidity during our exam. As we did our inspection on the posterior chest wall, we want to make sure that we have the patient draped for their modesty. We visually inspect the chest, looking for bilateral chest rise and fall. We can then place our hands bilaterally on the patient's chest wall, below the breasts on a female and male. And again, we're feeling for equal expansion. We're feeling for tactile fremitus. Again, once we've done that, we can go and percuss. Remembering that as we go down, you can either go straight down the chest wall or you can go side to side. Remembering that if you find an area of irregularity where you think there's consolidation, it would serve you to go above the area where you think it is and below it to see if there's a change in the sound's conduction. Remembering that in a air-filled lung, you're going to have hyperresonance. In fluid or pus, there's going to be hyporesonance. Once we've done the percussion, we would then move on to our auscultation. Anteriorly, remembering that we have on the right-hand side, we have the right upper, right middle, and right lower lobes. And on the left-hand side, we have the left upper and the left lower. Similarly, using our diaphragm, take a deep breath. Making sure that, of course, your stethoscope is against the skin. Reflecting the clothing back. And then to get the left lower, because our patients and our students will be wearing sports bras, if they are females, you can raise up to listen for the right lower. Remembering that when we're doing our lateral examinations, we can either do that from the seated position and from the semi-recumbent or recumbent position. On the right-hand side again, into the axilla, auscultating skin to stethoscope contact for our right upper. Reflecting shirt or bra down, our right middle. And then reflecting the shirt or bra up for right lower. Allowing a full inspiration and expiration. To demonstrate also, remembering that we feel the chest movement, we percuss and palpate, and then we auscultate, you can then do the similar percussion on both the right-hand side and the patient's left-hand side.